Okay, thank you for that introduction, and thank you to the conference organizers for inviting me to come and speak today. It's a pleasure to be among those welcoming you to my hometown of Vancouver and to talk a little bit about how drug policy should respond to the HIV epidemic. I have no financial conflicts of interest to declare, but do need to acknowledge the support of the Canadian Institutes of Health Research and the National Institute on Drug Abuse for the support of a lot of the research that I'm going to be presenting today. Several months ago, when I was thinking about what I would talk about, I was thinking, I have to have something really exciting to share with people, and then if you lived in British Columbia, you would have seen this let me back up. This headline from The Economist magazine describing Vancouver as mind-numbingly boring. So here I am trying to come up with something exciting, and it really just inspired me to want to tell the story of the HIV epidemic in Vancouver and the story behind data like this, which represent essentially a 90% reduction in new HIV infections and AIDS cases, and a close to 90% reduction in new HIV infections. So there's been a dramatic public health gains that we've been able to see. I won't be talking about the West End of Vancouver, which is the home of the gay neighborhood, where there's a great deal of pride and strength, simply only to say that by the time the HIV virus was identified, the epidemic was already fully entrenched in this population. Vancouver has another neighborhood called the downtown east side of Vancouver, which I will talk about, which is characterized by high rates of addiction and poverty, very serious medical and mental health challenges. And I don't care what The Economist says, Vancouver is a place where there's been a huge amount of drug use and problems related to that. And to emphasize that point, I thought I would share just a headline of one of the seizures, almost 100 kilograms of heroin that was seized coming into British Columbia. We're a port city, the ports of Asia to our west, and much like any North American city, we have major problems with drug addiction. What's very interesting is that these two neighborhoods that I've described, the West End, which is home to the gay neighborhood, and the downtown east side, this area of inner city poverty, it was well over a decade before HIV emerged among persons who inject drugs. And you can see here a headline from 1994 when this epidemic first began to emerge. Now, for several years, several of my senior colleagues presented to policymakers on what they were describing as deadly public policy, and this actually has recently been published. And I thought I would talk a little bit about some of these deadly public policies that contributed to the HIV epidemic. The first thing is the environment in the downtown east side, and there's, for those of you that have visited, if you look up above the street level, you'll see all these hotel-type living environments where traditionally these buildings were built for people who were working in seasonal industries. So people working in fisheries or forestry would come in the winter to live in these environments, and over time they become areas for people to live that are living in a great deal of poverty. And urban areas around the world have neighborhoods like this, which essentially is a single room, not much larger than the area that I'm standing, with a shared bathroom on that floor. Now, I don't want to be negative about my colleagues from law enforcement who put their lives on the line each day to protect public safety. I have friends and collaborators in law enforcement, but now in Vancouver we all acknowledge that huge policy mistakes were made in terms of trying to treat drugs as a criminal justice issue and really responding to this as a sort of an isolated strategy. So the point here is that what Vancouver did is it tried to clean up the public disorder associated with public drug use and had police sort of chasing people around to try and avoid visible drug use or drug dealing or all the other activities that go along with that. But unfortunately what happens when you do that is that it will improve visible public disorder, but it will drive people into these hidden locations. And this phenomena has been described internationally, and Vancouver is an excellent case study where people will go up into these single-room occupancy hotels, into abandoned buildings. In New York City, the sort of shooting gallery type environment would be classic, under bridges and viaducts and other hidden locations where the likelihood of interacting with police is less, but of course providing an HIV test or providing a clean needle becomes extremely difficult in these circumstances. Now, it wasn't all on law enforcement. There were problems on the public health side as well. Vancouver had a fair amount of notoriety, actually, because it did have a needle exchange program when the HIV epidemic emerged. But the reality is that for the whole metropolitan area of Vancouver, there was actually just one place where you could get a clean needle. To be able to do so, you had to bring a used needle to get a clean needle, and that program closed at 6 p.m. each evening, so it just had regular operating hours. And of course, for people that work in this area will know that 6 p.m. is when all the sort of drug use and other activity, sex work, and all the other risk behavior really gets going. And if you needed a clean needle at that time, there was no way to get one. If you take anything away from my presentation today, it's that this milieu of factors that influences behavior and ultimately HIV transmission, it's that they don't operate in isolation. So this is an example of a study looking at one of the needle exchange programs that opened subsequently to the first program, and then an operation, police operation called Operation 24/7, and the fairly dramatic reduction in clean needles that came out after that time. Another phenomena that emerged in Vancouver that was really just an accident of the drug market and organized crime was that British Columbia, as some of you may know, has had a long-standing cannabis growing industry, an illegal industry to support the export market and demand for cannabis in the United States. That industry is also intimately linked to the importation of cocaine and guns into Canada. And when this really got going in the mid-1990s, the organized crime groups in Canada weren't as sophisticated as their US counterparts. And they didn't know that it was more profitable to cook down powder cocaine into freebase smokable cocaine or crack cocaine. And they began selling powder cocaine on the streets of the city. So then people who had traditionally been using heroin began injecting cocaine with heroin or cocaine on its own. And because of the short half-life of cocaine when you inject it, which is only about 10 minutes, as opposed to heroin, which is upwards of 4 hours, people could go on a binge of injecting cocaine 20 or 30 times per day. And you can imagine in an environment when there's no access to clean needles after 6 p.m., this can have a huge impact on HIV incidence, and that's obviously what's shown in this figure. Very quickly, as a result of this, despite over a decade of not a lot of HIV infection in the downtown east side, the prevalence quickly rose to about 20%, and then by the time Dr. Stephanie Strathdy and her team initiated a NIDA-funded HIV cohort study, there was an HIV incidence of about 20% in the first 18 months of follow-up. So they basically established the study in the midst of a very, very explosive HIV outbreak. And working with the organization that's tasked with providing HIV treatment for all British Columbians, we were sort of calculating the costs and the implications in terms of morbidity and mortality, and obviously facing an extremely daunting task. Like every environment where HIV is a challenge, it's obviously not a challenge in isolation, and at the same time that this was happening, there were huge problems with fatal overdoses. So in the downtown east side neighborhood and surrounding areas, at the peak of the fatal overdose epidemic, there was about 1 fatal overdose per day. So ambulances running down there trying to resuscitate people, and 1 mortality almost daily. So just a huge public health emergency, and really a quagmire that left everyone sort of scratching their heads and saying, you know, what do you do when things get this bad? One thing that happened that really turned the tide was the empowerment of the community, and a huge number of people and different groups really starting to become extremely vocal. This is a picture of the president at that time of a group called the Vancouver Area Network of Drug Users, which basically, went after politicians for their lack of action. But it was a huge collaborative effort because of the people who were dying of HIV/AIDS, people who were dying of overdoses. You had parents groups coming together, an organization called From Grief to Action, working with politicians to help bring their attention that they couldn't bury their heads in the sand any longer. In recent years, we've had great support from our provincial leadership, but actually at this time, it was the city government that really took action. Our mayor, Philip Owen, and our drug policy coordinator, Donald McPherson, basically acknowledged that we couldn't keep doing what we were doing and trying to enforce our way out of this problem, and that we needed a comprehensive approach. There would still be a role for police, of course, because of violence and drug markets, etc., but we needed public health in the form of harm reduction, we needed strategies for prevention and treatment of addiction, and we needed an entirely new approach to go about this. The first thing was getting clean needles to people and educating them about the risk of sharing needles and empowering people who inject drugs to be actively involved at the forefront of this. So this is a picture of a needle exchange table out on the streets in downtown Vancouver providing clean needles by this organization. But essentially every health clinic became responsible for providing clean needles. This paper from the American Journal of Public Health by my colleague Thomas Kerr nicely describes the fairly dramatic reduction in syringe sharing as well as HIV incidence attributable to the harm reduction programs. And then the question we always get from policymakers when they visit us is, well, what about the negative consequences of providing all these clean needles? Don't you have a situation on your hands where you've got more people injecting all the time? And of course, people who work in this area will know that the international literature does not suggest this, and certainly the Vancouver data suggests this as well. So this is a paper from my colleague Dan Werb. The blue histogram shows the essentially the growth and where you can obtain needle exchange or clean needles. So in 2010, there were over 30 places where you could obtain clean needles. And then the box plot shows actually the significant increase coinciding with this of people who are no longer injecting. So I'm not asking you to infer causation from this, just simply that a culture shift has been observed in Vancouver where people are moving away from injecting despite the fact that there's free and easy access to clean needles. Also changes in policy in terms of if you didn't have dirty needles, you could still get as many clean needles as you wanted. Unfortunately, needle exchange is limited in its ability to address a number of other challenges the city was grappling with, and that includes high rates of public drug use, so people injecting in public in view of tourists and other people who are just going about their day, and of course the problem of fatal overdose. And needle exchanges do provide a point of contact. There is an opportunity for education and other interventions for overdose prevention, but that contact is quite furtive, and so in the face of this, Vancouver opened 2 medically supervised safer injecting facilities. The first is exclusively for people with HIV that's located in the west end of Vancouver called the Dr. Peter Center. They're doing tours daily for those that are interested. And the other is this program called Insight that's located in the downtown east side. It's a fairly nondescript storefront location. It's got all the sort of services of any medical clinic in terms of nursing and wound care. You can get an HIV test, you can get your viral load tested here, but unlike a traditional medical clinic, there's also a place where people can go to inject pre-obtained illicit drugs under the supervision of medical personnel. What this does and what the international experience with these programs shows is that it precludes the opportunity for syringe sharing because you're given a clean needle and you have to dispose of it as soon as you've finished injecting. Dirty needles don't end up on the streets or out in the community, and of course people are resuscitated in the event of an overdose. So despite the fact that there's been over 2 million injections within Insight, there's never been a fatal overdose. This is what some of the data look like. This is before the program opened, and then you can see the growth in use of the program after it did open. Now about 800 people inject there per day, and this is the decline in public drug use. And that was confirmed by the fact that there are syringe disposal boxes in the neighborhood that essentially people were using in sight, and they weren't injecting in the alleys anymore where those disposal boxes are located. This is a paper from The Lancet by my colleague Thomas Kerr showing the further gains in terms of reducing syringe sharing attributable to this program. Another paper from The Lancet by Brandon Marshall showed essentially a 35% reduction in fatal overdoses coinciding with this program's opening. In terms of addiction treatment, the story for Vancouver, I think, is yet to be told, and I'm excited about some of the directions that we're going, and I think in the next 5 years it will be really exciting, some of the things that we're planning to do here. But one thing certainly that we did get right was making methadone maintenance therapy available. It's a low threshold program here. It can be prescribed by primary care physicians and dispensed through community pharmacies, so not restrictive programs where you have to go to a methadone clinic. This is some work by my colleague Keith Ahmed that's actually in press at Lancet HIV, and you can see the fairly dramatic reduction in terms of rare instances of HIV amongst people on methadone versus individuals not on methadone having a much higher HIV incidence. Of course, in terms of the HIV response, it's not just the fact that methadone protects against HIV, and this data is consistent with meta-analysis published by the Cochrane collaboration, but also, of course, there's advantages in terms of antiretroviral therapy. As Nora Volkow alluded to in her plenary, we have data showing that people getting on methadone are much more likely to get onto antiretroviral therapy and, of course, subsequently adhere. The last pillar of the response has been treatment as prevention, and we're very fortunate in that we have a NIDA-funded cohort study of people at risk of HIV who use intravenous drugs, as well as a cohort of people who are HIV positive. And if you look at the sort of just very crude data, you can see that the median viral load was highest during the HIV outbreak and has gone down over time. The HIV incidence, because of some delay between measurement, but as you might expect, given what we know about treatment as prevention, was highest in the wake of the high viral load and then has come down over time. Of course, there could be many factors operating, including the availability of clean needles and other things as I've described. But if you look in a multivariate analysis from our data, even when you adjust for things like used syringe sharing, unsafe sex, daily cocaine use, you can see that the impact of the viral load in the community in the 6-month period since someone's last HIV negative test is the strongest driver of people becoming HIV positive. In terms of the cascade of care and the work to make antiretrovirals available, this is some work by my colleague MJ Malloy showing that in the community of a population that was traditionally thought to be difficult to treat with antiretroviral therapy, it's down to about 3% that are antiretroviral naive, and the vast majority are on antiretroviral therapy and undetectable. Again, this may lead to questions in terms of what about the consequences of that? What about non-adherence and resistance? And essentially, even in this population, because of the adherence support programs, antiretroviral resistance has become an extremely rare event. So what about the lessons learned and what can we take away from this? Certainly, I think we've seen, whether it be recent international epidemics in Indiana, in Greece, or the circumstances elsewhere, is that when these epidemics occur, they don't happen by accident, and they really have their origins in harmful policies and circumstances. The international data really show now, whether it's any harm from drug use, not just HIV infection, is the limitations of criminal justice approaches when applied in isolation. Not only do they not achieve their objectives of reducing the availability and use of drugs, but for people at high risk of HIV, they lead to huge behavioral changes that dramatically elevate the risk of HIV. Certainly, the importance of community empowerment and the role of community in bringing about change in Vancouver, I can't overstate. It was critically important. And lastly, the value of integrating these interventions. We talk a lot about the success of treatment as prevention in Vancouver, but we always need to make sure people understand that, you know, the work, the basic science work or the clinical work even that was presented this morning, when that gets translated in the community, it really requires an integration of various approaches. The public health approaches, helping to engage people in addiction care, helping to engage people on antiretroviral therapy, and it's really that integration that contributes to the success. Obviously, a story like this involves, you know, thousands of people, you know, the thousands of people who volunteer their time for research, the patients, the community members, the activists, the courageous politicians who eventually were sort of pistol whipped into action and did that in a lot of, against a lot of stigma for themselves when they did so. So with an acknowledgement to all of them, I thank you for your attention.